Okay, so this is week 2, OT 300. Week 2, the lecture PowerPoint. This is about the shoulder and as well as a lot of other kind of issues around shoulder, manual muscle testing, and kinesiology. Okay, these are the homework questions. I'll go over these in class. These are the answers to the questions. These are pretty straightforward. You see these answers to these questions, the answers in red. Let me know if you have any problems, you weren't on the same page with these kinds of answers. This is again a discussion we'll do in class. These are the lecture questions for today. So for next week, when you come in, next Wednesday the 15th, when you come in, be some of these lecture questions, 1 or 2 of those, and definitely all the anatomy for the shoulder, the motions of the scapula. Focus on that. Motions of the scapula. Motions of the scapula. So you need the motions of the scapula and shoulder and the motions in the anatomy of the shoulder. That is next week's quiz, and again, that's all listed in the modules on Canvas. If you the answers are right there if you're looking for exactly what you're going to be tested on. Okay, so muscle testing, we kind of got exposed to that a little bit in the lab, kind of getting into that more. Muscle strength kind of consists of strength and endurance. Kind of gives you some important clues to impaired function. And again, as occupational therapists, we're always thinking in terms of function. We're not so really worried so much about the strength and emotion and all that as we are as helping them do what they want to be able to do. Remember that example with the bowling or whatever it is, playing tennis, whatever it is you want to be able to do. How does this interfere with being able to do that? The loss of strength, the loss of endurance. Muscle weakness is caused by a lot of things. You'll see primarily when you go out in your rehab clinicals is just being in bed, disuse. A lot of our patients are kind of lying in bed for days at a time, and they just lose tremendous strength. Being older, in a lot of cases, more frail. Just being in bed all day, they're just weak as a rag doll, and this is kind of where we come in just to get them up and going again. So disuse, being bedbound, probably the primary cause of muscle weakness that we'll see. Neurological involvement, think if somebody's had a stroke, paralyzed, multiple sclerosis. Start messing with the nerves. Nerves kind of connect with the muscles and give them the muscle strength. If the nerve pathway is impaired somehow, you're going to get weakness. Trauma, the body's response to trauma. Like if you fracture your shoulder, all the muscles around that fracture become very flaccid and weak. So trauma leads to muscle weakness. Definitely as we age, pain. If somebody's in pain, they'll have muscle weakness. It's not really so much a strength issue as it is a pain issue. The body's again response to that pain is to be weak in that particular area around the trauma, the lesion. Illness, being sick can cause a weakness, different kinds of illness. Why do we need to assess muscle strength? We need to kind of show progress. It's a kind of clear way to show progress to insurances or third-party payers that they've gone from a 4 out of 5 to 5 out of 5 in muscle strength. It's just good to show patients that progress too, that the program that you're working on, the exercises, whatever, is working. They can see that they're getting stronger. Say, oh, last week you were 3 out of 5, now you're at a 4 out of 5, you're getting stronger. Really also helps show that your plan is working. You have this plan, you come up with it, start working with your patient, you get them where they want to get, and you test their strength initially, and then later on, oh, they're getting stronger, what we're doing is working, my ideas, my plan is working. And it really kind of helps you again, kind of analyze that movement, analyze that function, and really drive your treatment decisions. How do we assess muscle strength? There's a lot of different ways to assess muscle strength. We're talking about the manual muscle testing primarily for that first practicum, but there's other ways of doing it. We'll get into that. There's different devices that measure a dynamometer will measure your grip strength, pinch meter, how strong your pinch is. Just observing somebody, how much resistance can they take? Can they take 5 pounds, 10 pounds? How many reps can they do? Can they do If you ask them to do 10 reps and they only can do 5, obviously they're weak there. Quality of the movement, are they compensating? You ask them to kind of do a shoulder flexion and they're kind of twisting their body all around. It's telling you, you're observing, they're too weak to lift that weight, whatever it is. How long does it take them to do the movement? Sometimes they're very, very slow because they're very weak. Client's expression. Facially, are they kind of, look like they're in pain? Are they saying they're in pain? Some people will not say they're in pain, but they'll be lifting a weight and they're grimacing because obviously it's too much for them. Their physical reaction. SOB, are they short of breath? Is heart rate up? Are they turning pale? Are they perspiring? All these things give you clues as to how appropriate the right strength is when you're doing an exercise. And of course, there's the manual muscle testing. How do we address that weakness? We found out that they're weak and it's impacting their ability to do a particular task. How do we do it? OTs try to do functional activities. We do exercises, but that's kind of not the first choice. Our first choice is really to do an activity with a patient to address their weakness, endurance, specific exercises to develop that specific muscle, that key link. Reducing pain. We get modalities, massaging, get rid of the pain, they're going to get stronger. Stretching, muscle length, increasing the muscle length, can also help with improving their strength. Principles of manual muscle testing. This is something a lot of different disciplines do. PTs, OTs, athletic trainers, some physicians do it. It's kind of a universal kind of process, and it has a degree of uniformity to it if everybody's kind of doing it the same. You can address motions or the muscle. We're kind of getting at the motions in this class. It's a standardized technique, and it's accepted by insurances, commonly accepted. Doesn't require any special equipment. Has those 5 basic levels. You have to know the gravity planes. We talked about that already, but you have to kind of know how to position the body, whether it's against or minimized gravity. So you're assessing it in a uniform, standardized kind of way. Contraindications, there's kind of a continuum. These contraindications doesn't necessarily mean you're not going to do it, but you want to be cautious and kind of understand the chart thoroughly, talk to the physician if you have kind of questions about this. Excessive pain, obviously we don't want to be pushing on somebody if they're in a lot of pain. Might have to kind of put them in a different position so they're not hurting when we're doing it. Definitely fractures, a hernia. Spasticity. What is spasticity? This is something that happens after you've had a stroke. You start messing with the brain cells, the nerve inputs coming down. Your brain cell kind of loses the ability to kind of regulate the correct amount of muscle tone. So you're not too tight, not too loose. After a stroke, this is kind of all wonky and out of whack, and a lot of times people have it really tight. They call it spasticity. In that case, it's kind of deceptive to check out their muscle strength. Fatigue, if they're too fatigued, confused, they're just too confused with dementia or whatever. Certain cardiac restrictions, especially anything above shoulder height, to be really cautious about. Talked about range of motion. Kind of why do we measure range of motion? We'll get more into this next week, but just to kind of keep hitting on that. The range of motion, we do that like with the manual muscle testing so we can have a baseline, show progress to insurances. Why do we compare active to passive? If you think about it, comparing active to passive tells us a lot. So if active and passive are the same, if you think about it, say they can only lift their arm halfway, and then when you passively move it, it only goes halfway. That's really telling you it's an issue with the joint. Whereas if it's the other way around, actively they only can go halfway, but passively you can go all the way. It's telling you it's an issue around strength. So again, that will drive your treatment decisions, whether you're working on the joint or the muscle. Why do we need to compare the affected side to the non-affected side? Everybody has a different idea, a different kind of normal. We're all kind of within a range, but there's kind of a wide range of what is normal. So if you compare their normal to their injured side, it'll give you the target. You want to get it back to what their normal is. If their normal is only 4 to 5, then that's what you want to get it back to. If their normal is only 150 degrees of shoulder flexion versus 180, that's the normal we want to get them back to goal-wise. Here's our levels again. 0, nothing. On that trace, you can feel some active palpation of the muscles. They're contracting. There's no movement there. Poor, they cannot go all the way up against gravity. 3, fully active against gravity, no manual muscle testing. For good full action, this is pretty good, close to normal. They can take that moderate push, and then 5, they can take that max push there, 5 out of 5. How to perform MMT. We'll demonstrate this in the class. Key things here, ask the client before you even start, let me know if you're in any pain or this causes any pain. You're going to ask them to demonstrate that full motion, and then you're going to start positioning them. And if you need to manual muscle test them, you may not need to manual muscle test them. Push on their arm. You have them in the right position. Don't let me move your arm. Stabilizing proximally and pushing in the opposite direction of the desired movement you wish to access. You're going from that minimal, moderate to max. When you're documenting this, we'll hold you again for this, and the practically you have to document it right or you're going to get it wrong. It has to be over 5. Always over 5. So it's like 1 over 5, 2 over 5, 3 over 5. And then you can kind of abbreviate. AG is against gravity. Minimized. MG. Again, you're only pushing if there are 3, 4, or 5. If you ask them to go fully against gravity and they only go part of the way, you know there are 2. They can't do anything. You don't know whether they're 0, 1, or 2, and you have to put them in a minimized plane. But again, no more pushing. If they're below a 3, there's no pushing. Okay, so let's get into the shoulder anatomy, a little bit of the kinesiology of the shoulder. Here's the key anatomy. Here's the clavicle, the SC, sternoclavicular joint. Here's the AC. People separate their shoulder. The acromioclavicular joint. This is usually where it happens. These names kind of tell you where they're located. So obviously this is connecting the sternum to the clavicle. This is connecting the clavicle to the acromion, which is the top of your shoulder. The key joint we're looking at in here. Humeral head sitting in that glenoid fossa. That's the glenohumeral joint. That is really the heart of the shoulder joint. It's all the shoulder joint, but really that's the heart of the shoulder joint. We'll talk about the shoulder joint, issues of the shoulder. It's usually an issue with the glenohumeral joint. Scapula, humerus. This would be the proximal end, the distal end. There's the bicipital groove. Sternum. The kinematics. All these different planes of movement of the shoulder. There's all these great planes of movement. It goes everywhere. It also makes it highly vulnerable. It easily can separate. Here's the abduction going straight across. I'm sorry, this is adduction, ADD, coming right across towards midline, and then abduction, coming back out. Shoulder flexion, it's not too great, but they're coming straight up and down. Internal lateral rotation or medial and lateral rotation, circumduction. Just goes everywhere, the shoulder. It spins. Look at this one right here, internal and external rotation, or medial and lateral rotation. So this humerus, it literally spins in and spins out. You start talking about all those great rotator cuff muscles that are usually the focus, in all cases, the focus of your shoulder treatment. You start seeing shoulders, injured shoulders. It's an issue around internal and external rotation. That's what the rotator cuff muscles do. They internally rotate it, externally rotate it. Start thinking about this as a kind of spinning in, spinning out. Flexion and extension is straight up and down. Abduction up to the side and down. Here it is, kind of in action. It kind of rolls and glides in that joint. You can see how vulnerable it is. There's the glenoid fossa, humeral head. It's kind of like a fist into your palm of your hand, and it's just rolling and gliding all over the place as it does all those different motions. To be moving the right way it should be, good biomechanics, and not off. Any kinds of little tilting one way or the other causes pain and all kinds of problems. It needs to be perfectly set in there. It's almost like a ball. Somebody described it as like a seal balancing a ball on their nose. It kind of has to be right in there in the right spot. Humerus, abduction, all that sort of stuff. Here's the bursa. A lot of times we have shoulder bursitis that's getting swollen. So like I said, it rolls. See how it kind of rolls down. If you abduct your shoulder, lift your shoulder up to the side, it rolls down and back. Kind of a rolling action. Kind of like a tire rolling down the road. As he lifts his shoulder up to get his shirt on, he's rolling that glenoid humerus and the glenoid fossa, that GH joint. It's also gliding. Kind of your fingers are a great example of how it kind of glides in the different joints. Glides here. See how it's gliding down, gliding on this surface here. And then it spins. It just literally spins. There's a joint in the knee that spins. Think of a doorknob spinning, tires spinning. And again, it's internal and external rotation. It's spinning in, spinning out. That's kind of that basic kinesiology of the shoulder. And with the shoulder, it kind of does all three. It spins, glides, and rolls. And it does it all together, usually. It's going to get very complicated. Don't need to get too much into the complications of it. But you need to kind of know that it does spin, glide, and roll. Because you need to know the kinesiology in a basic level, because when things go wrong, and believe me, they go wrong with the shoulder, it's going to be your job to go in and figure out, okay, what's wrong, which part of this is off, and there's different techniques, mobilizing the joint and stuff, that will help kind of realign it the way it should be, in a sense. All right, here's a shoulder anatomy from the back. Here's the huge traps, huge deltoid. This is the big agonist for a lot of these shoulder movements. Back of the scapula, you're going to get into this pretty quickly in your cadavers. All those great rotator cuff muscles. Here's the supraspinatus. This one slips under the acromion. See how it attaches to the top of the humeral head, and it just brings the shoulder up like this. You can visualize it as it contracts, it pulls it up. And then these guys in the back, key muscles, infraspinatus, teres minor. Minor is pretty small, infraspinatus is pretty big. It spins it out when you externally rotate. There's the rhomboids. As you know, retract the scapula, the big lats, big stabilizer, teres major, all those key muscles. There's a side view. See that big deltoid again. There's the minor, the infraspinatus, those external rotators. Is that serratus? The key muscle we haven't got out yet is that. There we go. This is the subscapularis. This one's deep under your armpit. It's a key rotator cuff, rotator cuff muscle. Commonly, it's very, very sore. It internally rotates the shoulder, spins it in. It's usually very tight, very sore. A lot of times as a clinician, you're going in there with gloves and you're massaging it, trying to calm it down, stretch it out. Here's the deltoid. This deltoid is so big and so key, it has really three different parts to it. We kind of break it down into three different parts. Anterior, just kind of here, right here as well. It's the front part, key part in the shoulder flexion, bringing the shoulder right up like that. Middle part, middle deltoid, along with the supraspinatus, it abducts, lifts your arms up to the side. Think of angels in the snow. And then the back part, this is a back view, posterior. It helps with extending, lifting, putting your arm to extending your arm into the back kind of thing. Okay, so let's look at the first one. Shoulder flexion, that is the anterior deltoid. That is the big agonist with there, big thick wad of a muscle for most of us. It has the myotomes here. You don't need to know the myotomes for this class. You will probably at some point with other classes. What is that? That just tells you where the nerve starts. It's like axillary nerve that goes down to the deltoid. Starts, C6 is the cervical bone, C5, C6 right up on here. Comes down, attaches to the nerve. And that's kind of the, if you think about a light, like the wire that goes to the light, it gives you light. This is the wiring that goes down to the deltoid that makes it work. Somebody paralyzed, damaged that cervical bone nerve, this muscle shrinks and doesn't work. So it could be aware of these. Don't need to know it again for this class, but they're just there. Here's shoulder flexion again. You can see it functionally. You just use it all the time. She's reaching up to clean and to paint. You don't use that pure flexion that she's showing here, but you use a degree of it in different kinds of planes. Really key functional movement, functional muscle to get going. A lot of times with patients, they've fractured their shoulder. This muscle is just kind of wasted away. They've had a stroke. This muscle is kind of wasted away. This is the key part of your therapy, usually early on, trying to get that deltoid going again so they can lift their arm up, do anything, really. Get their shirt on, wash their hair, feed themselves. Functionally, this muscle is huge. People need to get that back, and a lot of times you're focusing your treatment on that muscle. Okay, I think I'm going to stop this.